Cushing syndrome, a state of hypercortisolism of any etiology. These may be due to either ACTH-dependent or independent processes. Let's turn first to ACTH-independent processes, and these occur when the adrenal gland produces cortisol directly, such as from an adenoma, carcinoma, or hyperplasia, and account for approximately 5 to 10% of the causes of Cushing syndrome. The most common cause of Cushing syndrome that it happens to be ACTH-independent is iatrogenic, that is when we give patients steroids. Now, the other causes of Cushing syndromes are ACTH-dependent cortisol production, and these may occur when a pituitary adenoma produces ACTH stimulating cortisol production, and that defines Cushing's disease and accounts for about 75% of Cushing syndrome if one ignores iatrogenic causes. The other ACTH-dependent cause of cortisol production is ectopic ACTH secretion, such as from a small cell carcinoma of the lung. Regardless of the cause, the manifestations of hypercortisolism are shown on the slide with red cheeks and moon faces, centripetal obesity with thin limbs, and these purple violaceous striae. Other manifestations can include high blood pressure and hyperglycemia. Here one can see the moon faces that are prominent in hypercortisolism and the violaceous striae. The evaluation includes first screening for Cushing syndrome when one suspects it by checking an AM cortisol after giving the patient 1 milligram of dexamethasone at bedtime, or alternatively checking a 24-hour urine for cortisol. If the AM cortisol is suppressed or the 24-hour urine cortisol is normal, one has effectively ruled out Cushing syndrome and is done. On the other hand, if it's elevated, then one needs to confirm this diagnosis, and one can do this by administering a low dose of dexamethasone, approximately 0.5 milligrams every 6 hours for 48 hours, and then rechecking the cortisol. If this is in the normal range and suppressed, then one has ruled out Cushing syndrome and one is done. On the other hand, if it's elevated, one has defined Cushing syndrome, and now one needs to evaluate the cause. One does that by checking the ACTH in order to distinguish ACTH-dependent from independent causes. Should the ACTH be low, one clearly is dealing with an ACTH-independent cause and adrenal cortisol production, and one should image the adrenal glands. On the other hand, if the ACTH is elevated, one has an ACTH-dependent cause, and there are really two possibilities here. One is pituitary production of ACTH, that is Cushing's disease, stimulating cortisol production from the adrenal gland, or alternatively ectopic ACTH production, such as in small cell carcinoma of the lung. To distinguish that, one does a high-dose dexamethasone suppression test, as shown, and then rechecks the cortisol. It turns out that the pituitary gland, when it has an adenoma producing ACTH, can still be suppressed with this high-dose dexamethasone suppression test. So a cortisol level after that high dose that is suppressed suggests, in fact, Cushing's disease, a pituitary adenoma, and the pituitary should be imaged with an MRI. On the other hand, if that cortisol is still elevated, it shows non-suppression and would be very suggestive of an ectopic source of ACTH, and lung imaging should be performed.